Good evening, everyone. So let's discuss the fourth part of our series on antiretroviral therapy. In the previous two parts, the part 1 and part 2, we discussed the six major classes of ARV drugs. Okay, and we have discussed all the six major classes in the previous videos. And if you are a Sapphire member, in the part 3 of antiretroviral therapy, we have discussed newer drugs in the management of HIV. Now the fourth part will comprise of prophylaxis. Okay, so in this part, we are going to discuss the prophylaxis of HIV. And by prophylaxis, we mean the drugs because in the next part, next week, we'll discuss vaccines in HIV. So this week, we'll discuss only the drugs in exposure prophylaxis. And we'll discuss both post-exposure prophylaxis and pre-exposure prophylaxis. But the major part of this week's lecture will be on post-exposure prophylaxis. Clear? So without much further ado, let's start our discussion on antiretroviral therapy part 4, exposure prophylaxis. Let's start. We know from our previous lectures on the HIV series that HIV infection takes hold in the body in in a matter of few hours. So 24 to 36 hours the infection is there. That means the HIV virus has infected your circulating lymphocytes and has implanted or integrated its own genome inside the host genome. And that is when the HIV virus has taken hold of the immune system. And now it will keep on getting multiplied throughout life. Our job as a doctor treating the HIV infection is to keep the replication as minimum as possible to barely detectable levels, which is roughly at about less than 50 copies of RNA per ml. I'm not too sure about this metric, but I'll confirm that in future videos. Now, we have to stop the HIV virus to integrate its own genome in the host genome, and that is where prophylaxis comes. Okay, the main motive of prophylaxis is to prevent this integration of genome. So for that, we have to start it as soon as possible. So PEP, whenever I say PEP, it is post-exposure prophylaxis where the exposure has already happened. So post-exposure prophylaxis, within the 72 hours from the exposure, we have to start PEP, preferably within 2 hours of exposure. So these two metrics are very important. First 72 hours, preferably within 2 hours of exposure. Clear? PEP has to be stopped when it is completed. That means about 28 days of PEP has been taken, or you find out that the source, the patient or any source from where you might have contracted the injury and you have a suspicion of HIV transmission, if the source is found to be HIV negative, then you stop PEP. Or you have prescribed PEP and now the source was found to be positive and the exposed individual is also found to be HIV positive, then you start treatment for HIV, you stop prophylaxis, you start the treatment. So PEP is stopped if 28 days are completed, or if the source was found to be negative, or if if the patient is now found to be positive, you shift to antiretroviral treatment, you stop prophylaxis. Clear? Let's move forward. Now, what are the indications to start PEP? The exposure has happened within 72 hours. Okay. Plus, the source does not have a good viral suppression or the information about the source is not available. What do we mean by that? The indication to start PEP is that the needle stick injury or let's say any kind of exposure has happened within 72 hours and the source. So whenever I say source, that means the patient or the individual whom we suspect to have HIV, okay, from where the body fluid has come, and the exposed. Whenever we say exposed, that means the person who got the injury and will now is being considered for PEP. So that is exposed. So remember, source is from where the infection might have come, and exposed is the individual who got exposed to those body fluid, and we are now considering post-exposure prophylaxis for the exposed person. Clear? If the information about the HIV status of the host is either not known or known to have HIV, but the virus suppression is not adequate, or we say HIV positive individual. Okay. So whenever these are met, you consider the exposed person to take PEP. Non-occupational PEP is not recommended if the exposure has no substantial risk. So we will discuss about what is the high risk or low risk. But let's say a splash of blood, so that is not, if it's on an intact skin, so it's a very low risk, in fact a no risk transmission, so you don't have to give PP in that scenarios. NPP or non-occupational PEP is stopped if the source is found to be HIV negative. So if there's no HIV in the source, there's no reason to suspect any transmission, so you stop NPP. Clear? Let's move forward. Now, these are the body fluids which are considered at risk. That means the transmission rate of HIV from the source to the exposed is higher when these body fluids are there in discussion. These include blood, semen, vaginal secretions, CSF, body fluids like synovial, pleural, peritoneal, pericardial, or amniotic fluid, internal body fluids, and other body fluids which are contaminated with visible blood. The most important fluid at risk is blood, and the next is the semen and vaginal secretions or genital secretions. Exposure to body fluids who are considered not at risk. These are those body fluids in which the rate of transmission is negligible, if there is. Most of the time it is none. So consider these body fluid as not at risk, and these include tears, sweat, urine and feces, saliva, sputum, and vomitus. So all of these fluids, if they are not contaminated by blood, so there have to be no contamination, not contaminated by blood of the source, then these are considered to be non-exposed or not at risk body fluids. Clear? Let's move forward.
Hi, hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. You get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video.
So let's discuss the drugs which are recommended as post-exposure prophylaxis. As per CDC, the recommended regimen is of 3 drugs. 2 drugs are fixed and 1 drug is variable. The fixed drugs are tenofovir 300 mg once a day and emtricitabine 200 mg once a day. So these 2 drugs are fixed. T, E, or in other notation it is written as F/TDF. Okay, so emtricitabine 200 mg once a day, tenofovir 300 mg once a day. These 2 drugs are free. They are fixed. The third drug can be either raltegravir 400 mg twice a day or dolutegravir 50 mg once a day. Now remember the difference in the regimen. Raltegravir is twice a day while dolutegravir is once a day. So it becomes, it is understandable that you would like to combine dolutegravir with the above 2 drugs, because then all the 3 drugs are once a day and all the 3 drugs can be combined to form a single pill which can be taken every day as a part of PEP. Clear? So the most common regimen that is followed is a fixed drug combination of tenofovir 300 mg, emtricitabine 200 mg, and dolutegravir 50 mg taken once every day for 28 days. So CDC gives these 3 drugs for 28 days. Clear? Let's move forward. Now, we have discussed about the CDC recommendations. From this slide, we'll discuss the NACO recommendation. And for us living in India, NACO becomes important. So we follow the NACO guidelines. The NACO 22 guidelines for adults and adolescents recommend the combination of 3 drugs. It is tenofovir 300 mg once a day, lamivudine 300 mg once a day, and dolutegravir 50 mg once a day. Clear? So the regimen is T, L, D, tenofovir, lamivudine, dolutegravir, and that is the latest recommendation for post-exposure prophylaxis. This is the same regimen which is recommended as treatment for HIV, but the difference is that PEP will be stopped after 28 days, while antiretroviral therapy will keep on continuing for life. Clear? Now, the previous year's regimen was TEL, but now the E has been changed to dolutegravir. Clear? The recommendation is for patient or exposed individuals where the weight is more than 30 kgs and age is more than 10 years. Clear? It is for 28 days like we have in CDC. So repeat after me. Three drugs as per NACO for post-exposure prophylaxis is tenofovir 300 mg once a day, lamivudine 300 mg once a day, dolutegravir 50 mg once a day, and all these three drugs come in a fixed drug combination or a single pill to be taken as post-exposure prophylaxis. Clear? Now let's move forward and understand the modifications of these three drugs. Another alternate regimen after TLD is TLE. Tenofovir 300 mg once a day remains same. Lamivudine 300 mg once a day remains same. The only change is that you replace dolutegravir with efavirenz 600 mg once a day. Okay, so efavirenz is 600 mg once a day and comes in place of dolutegravir. But remember, the recommended regimen, the first line regimen is TLD, but you can use TLE if there's any issues with using dolutegravir. Clear? Let's move forward. Another regimen is instead of efavirenz or dolutegravir, you give lopinavir 200 mg plus ritonavir as a booster 50 mg, one tablet, two tablets twice a day. So what do I mean by that? Tenofovir 300 mg remains same, lamivudine 300 mg remains the same, but the third drug is a combination of lopinavir 200 mg, ritonavir 50 mg. These two drugs together come in one tablet. You have to take two tablets twice a day. Clear? Two tablets twice a day, lopinavir 200 and ritonavir 50 mg. Now, in the second part of antiretroviral therapy, where we were discussing protease inhibitor, we have discussed the combination of lopinavir and ritonavir as an antiretroviral protease inhibitor therapy. Clear? In this case, ritonavir is being given as a pharmacological booster, like we have discussed before. So go back to the second part of antiretroviral therapy to see the combination of lopinavir and ritonavir. Clear? So this is the alternate regimen as per NACO 22. Let's move forward. Now, in children, instead of giving tenofovir, we give zidovudine. Remember, while in the part 1 of antiretroviral therapy video, we were discussing that zidovudine is a very good drug. It reduces parent to mother to child transmission by about 70% and it's a safe drug in children. In fact, it has been recommended as per NACO and CDC to be used in children more than 3 months of age. Clear? And there have been multiple articles in using zidovudine in less than 3 months also, but it has not been recommended by the guidelines, but the use has still been there. You can go and read about individual uses in less than 3 months of age. Other drug that has been used in less than 3 months is nevirapine, and these two drugs, zidovudine and nevirapine, is used in post-exposure prophylaxis in children or in neonates. So if any of you want a separate video on post-exposure prophylaxis or treatment of HIV in neonates and pediatric population, you mention that in the comment section. If I get enough comments, maybe I'll make one more video about pediatric population. Clear? So in children, NACO 22 recommends zidovudine 18 to 24 mg per kg once a day, lamivudine 5 mg per kg twice a day, or 10 mg per kg once a day, depends on if the patient is tolerating or not, along with dolutegravir 50 mg a day. Clear? Let's move forward. Good evening everyone. I hope you're enjoying this video and I've come again to ask you to vote for Delhi for Dermacon 2028. So with the support of IDBL Delhi State Branch, do vote for Delhi and come and meet all the dignitaries here and let's have a good academic discussion in the backdrop of the cultural heritage that Delhi offers. So enjoy this vibrant city that I duly call my own and if you follow this instruction to become an e-voter, you can just easily vote on the IDBIL website. It hardly takes less than a minute, and it's better to vote as early as possible. Will help you in tackling all those spam calls that you get. So make sure that you choose Delhi as a good venue in 2028, and let's meet there. I shall see you in Delhi. Bye bye. So, in the last segment of the lecture, in the previous segment, we have discussed about post-exposure prophylaxis. Now we will discuss about pre-exposure prophylaxis. Now, what is the essential difference between pre-exposure prophylaxis? Prophylaxis means giving a drug to prevent the disease from happening. That is prophylaxis. Post-exposure prophylaxis means giving a drug to prevent a disease from happening after an exposure to a suspected individual has happened. And pre-exposure prophylaxis is giving a drug to prevent the disease from happening even when the exposure has not yet happened, but you think that the exposure is very likely to happen in the future. So if there's an increased probability of exposure of the exposure happening, you give drugs to prevent any kind of transmission of HIV. Clear? So pre-exposure prophylaxis, exposure has not happened but likely to happen. And post-exposure prophylaxis is exposure has happened but HIV disease is not present. Clear? So let's discuss pre-exposure prophylaxis. Now, the recommended drugs for pre-exposure prophylaxis is emtricitabine 200 mg and tenofovir 300 mg once a day dose. Remember, these two drugs are those drugs which are the fixed drugs in CDC recommendation, and the third drug keeps on changing. Clear? So in post-exposure prophylaxis, you have three drugs for 28 days, while in pre-exposure prophylaxis, you have two drugs, emtricitabine 200 mg and tenofovir disoproxil fumarate (TDF) for 300 mg once a day. This comes by the brand name of Truvada. Clear? Another regimen, an alternate regimen, is emtricitabine 200 mg and tenofovir alafenamide 25 mg. The difference is that in the second regimen, it is tenofovir alafenamide. Tenofovir alafenamide is a newer drug which has been approved for pre-exposure prophylaxis. So a combination, a fixed drug combination of emtricitabine 200 mg and tenofovir alafenamide 25 mg has been recommended as a once-a-day therapy for pre-exposure prophylaxis. Whenever we say tenofovir, we mean tenofovir disoproxil fumarate or TDF. Okay, alafenamide is a newer congener of tenofovir. It comes under the trade name of Descovy. Now, the efficacy of disoproxil fumarate and alafenamide is same. So the efficacy against HIV virus is same for these two drugs. There is only slight difference between tolerability and side effect profile. Okay, for example, alafenamide has low renal and bone toxicity. So you can give patients who have somewhat of compromised renal function or bone toxicity. And but alafenamide has higher risk of dyslipidemia and higher cardiovascular risk. Okay, so more lipidemia, more risk as for CV and stroke and other features, low risk on renal impairment and bone toxicity or osteopenia or osteoporosis. Clear? So this is just the difference between these two. Now, for pre-exposure prophylaxis, according to NACO, NACO has recommended only oral drugs, no injectable drugs, only oral drugs. And the recommendation is same. It is emtricitabine 200 mg or tenofovir 300 mg once a day, or lamivudine 300 mg or tenofovir 300 mg once a day. So remember, these two drugs are the same two drugs which are fixed in the post-exposure prophylaxis. The third drug is optional. But in pre-exposure prophylaxis, NACO recommends emtricitabine 200, tenofovir 300 or tenofovir 300, lamivudine 300. Clear? Any doubts anywhere in the exposure prophylaxis, mention that in the comment section. It's a very difficult thing to understand and remember, but if you make sense of it and understand why things are happening this way, it's easier to remember. Tenofovir 300 mg is same, only it is combined with emtricitabine 200 mg. or lamivudine 300 milligram as an oral regimen. NACO only recommends oral regimen for pre-exposure prophylaxis, while CDC recommends cabotegravir 2 monthly injection or lenacapavir 6 monthly injections also. Clear? So these are some reading recommendation. I would like to recommend reading, if you have time, the NACO 22 guidelines. It's available free of cost on the internet. The CDC guidelines to 2021 and 2022 update. Those two are also available on the internet. But I would really recommend that you should read the NACO guidelines, because in India that's what we use, and it explains a lot of information in the NACO guidelines are there. But most of the information we already know. We know how to wash hands with normal running water and soap after exposure. We have to decontaminate ourselves, report to a casualty center, take that first tablet within 2 hours. All things we already know, so I have not stressed on that fact. I've stressed more on the drugs which are in PEP. Clear? If you're finding these videos useful, do consider becoming a Ruby member. The membership gives me a lot of motivation to look for newer topics. And if you really like these videos, consider becoming a Sapphire member of the channel. I always put a post on polls for deciding the next series of lectures to the Sapphire members. In fact, at the end of this video, I've already put up a poll there to ask for what next topic we should tackle after the HIV series is over. So do consider becoming a Sapphire member. Remember, I do plan to stop Ruby membership after a few months. It will be helpful if you become Sapphire member. So with that, I shall finish this week's video lecture on antiretroviral therapy part 4 on exposure prophylaxis. Part 1 was NRTI and NRTI. Part 2 was all the next 4 class of drugs. Part 3 were the new HIV drugs, and part 4 is for prophylaxis. And I will not take much of your time. I'll stop the video here. Adio and bye bye. We'll meet next week when we will discuss vaccines in HIV. Clear? Bye bye.